Good morning. My name is Dr. Tim, and it is an honor to be here today. I'd like to thank Dr. Griggs and everyone in the organization for the opportunity to be here and share your time and some thoughts and some experiences that illustrate how we need to elevate the conversation and change the narrative from the transactional to the translational, and that this is a human journey and one that we will all experience with absolute certainty. It is an exciting time to be a physician. I hearken back to my days in graduate school studying molecular biology when the race to crack the human genome was on, and how far we've come since then, and therapies that are available to us that can transform our practice and provide opportunities to extend life and quality of life across not just oncology, but the entire field. We do specifically identify oncology with immunotherapy and things like that because of the crowd today, and I offer it is transcendent, but we need not lose sight of the translational aspect and the opportunity to not lose sight in the midst of technology what is really important, and that is the human being. I hope today to share a few thoughts, reflections, experiences over the last 15 years of practicing medicine. I come from several perspectives. I am an internal medicine physician, but all I've ever practiced is hospice and palliative care. So practicing physician in a hospital, ambulatory center, long-term care, home visits, changing the proverbial urine-soaked sheets year in and year out, being the only person on call for about 15 years. I served on the board of one of the larger health systems of this country 10 years ago with the development of accountable care organizations, tried to lead systems that care for people from volume to value. Some insightful lessons. The one that screams the loudest is that the 3 years serving on the board, I never heard the word patient once. I'm involved now in education development, policy, research. I've served as an attending for fellows, residents, students. I've spoken all over the world. I act as a consultant. But I think most significant for our conversation today is the perspective of a caregiver that I walked with my own mother a year and a half ago, who had rapidly progressive early onset dementia as well as end-stage lung disease. And what I would offer is an undiagnosed cancer. 50 years of 2.5 to 3 packs a day smoking, 80-pound weight loss in the last 7 months of her life. And much like your mother, my mother was very stubborn and a very irreverent Irish woman who was very clear on what she wanted and what she didn't want. I received a call early August 2017 that my mother was in the emergency department. She had fallen the night before, and my father, being the primary caregiver, as she was adamant at staying at home, and to quote her, come hell or high water, she wasn't going to leave. He sat on the floor with her all night long, comforting her, not able to move her, and so he did the only thing he knows. He called 911. They took her to the emergency department. At that time, he called me. I talked with the attending physician, and he said, we have lined up cardiology, nephrology, neurology, pulmonology, ology to the 5th power. And I said, let's take a deep breath, if we could, please, because you're viewing one moment in this person's journey. And let's talk about who she is and what she wants and how we can deliver against that. So I shared with her my mother's journey, the goals of care, that we had had many conversations which really represent absolute, true informed consent, the empowerment of what we're dealing with, what that is going to be moving forward, and asking what is important to her. I said, we've drawn some labs, you've already gotten a CAT scan. I would encourage us to make a referral to hospice if we could keep her comfortable overnight. I'm driving in. We'll make arrangements to transition her home. Arrived the next day. It happens to be the facility that I trained at. And in comes the gaggle of attending residents, medical students, pharmacy, social work, chaplaincy, and there were a few other people who were just tagging along. And the dehumanization of this process was they started to talk directly to my mother, who was unresponsive. And I said, let's just take a deep breath, please, and introduce all of yourselves. And let's focus on what's important, and that's the goals of care. And here's what we're going to do pursuant to what my mother wanted. It was somewhat of an affront to this group. But again, it's not about us as physicians or other providers. It's about the individual. We went home and celebrated the last 2.5 weeks of her life. My family came, my brother and his family came. That's not to say there was not grief and sadness, but it was honoring who she is and how she lived her life. Our oldest, washing her hands, changing the subcutaneous pump, 11-year-old Oliver. Our middle child, Matilda, dancing hip-hop around the bed to celebrate who Grandma Karen was. And our youngest, Maribel, eating cookies in bed and making crumbs everywhere, which I know my mom would like. And so I remember the morning, it was about 4:30, September 3rd. This is the house that I grew up in. And I awoke early. And the sounds of the house were those that I remembered from childhood, the smells, the feel of the carpet on my bare feet as I walked to the living room where she was. And I stood at the precipice of the hallway in the living room, and I knew that she had died. But what was comfortable for me was to approach and check a pulse and do this and do that. But much like that hug, I put my ear to her chest to listen for the proverbial heartbeat. And 5 minutes later, I realized what I really needed and wanted was my mom to hug me and say, it's okay. At 50 years of age, having practiced palliative care and hospice medicine, I was little Timmy with a teddy bear. It was a human experience. And thus illustrates the paradox and the challenge we face as providers and as physicians, regardless of specialty. How we are trained, what we are thought to need to do versus what we would choose for ourselves. When asked time and time again, we know that evidence suggests and research demonstrates we would not choose the path most often offered to our patients. And that gives me pause that maybe there is a disconnect between who we are as human beings and who we are as providers when we put on that proverbial long white coat. We know that 85% of patients would like to die at home. We know that 85% of patients don't die at home. So there's a disconnect, and I think we need to challenge ourselves with why that exists and bring forth a paradigm to understand how we can elevate clinical practice beyond doing things to someone so that we can do things for someone and with someone. So we can transcend medicine. I think there's several reasons why this exists. I think there's societal perception, particularly in this country, but not limited to the United States. I think it's most industrialized countries. I've had the honor of speaking all over the world, and the conversation is the same, that if you age and you are disabled, then you have done something wrong. If you are not on the cover of GQ or Vogue magazine, then you are on an errant pathway. I'm never going to be on the cover of GQ or Vogue magazine. And I am going to age. And I am going to become disabled. I think our society has tried to meet that challenge by talking about death more openly, death by design, death over dinner, death cafes. And I think we're missing the point slightly. Well, I think the conversation has value. We have put death in front of life. Truth be told, immunotherapy, everything else, every person on this planet, every patient we see is going to die. Absolute certainty. We need to change the narrative from death to life. There's a line in the sand that we need to respect, we need to honor, we need to acknowledge that we cannot change that inevitability. When we lead with death, we lead with fear. 77-year-old woman I was caring for who had a recurrent breast cancer metastasized to her brain. Conversations in her home. I want to stay here and be comfortable. Fair enough. Several weeks into her care, her son came to visit, was staying with her, and it was a Sunday evening that she started to experience some shortness of breath and chest pain. And so he did what he knew. He called 911. He didn't do anything wrong. He was scared and he wanted to care for his mother. She was transported to the emergency department. I came in the next morning and saw that she was on my list of patients to see, and I queried why that is, given her goals of care, her complete understanding of the disease. She was brought to the emergency department, and in spite of an EMR, where we had integrated a header for every palliative or hospice patient, highlighting that, elucidating the goals of care, giving my name and personal cell phone number, chest pain, shortness of breath, cardiology was called. Hospice patient, recurrent cancer, metastasized to brain, goals of care, stay at home, comfort, etc., etc. Cardiology comes. The initials of this cardiologist, and this is not in jest, this is real, are JC. And he had referred to himself as such many times. A little bit of renal failure, troponin bumped a little bit, shortness of breath, chest pain, history of heart disease. He asks, do you want to die? Leading with fear. I've never had a patient in my entire career say, sure. We need to take you to the cath lab. Results of the cath lab, absolutely negative. She was throwing blood clots from her legs to her lungs. Chest pain, shortness of breath. I went to the ICU where she was, and the crash cart was there moments before they were to intubate her. She was still lucid enough and competent. She looked at me and she just shook her head. I said, stop. Picked up a phone, called cardiology clinic. This is Dr. Ihrig. We have a mutual patient. She came in last night. She's in respiratory failure. She wants not to be intubated. I think we need to transition her back home to hospice. Click. Being a palliative care physician, my cell phone was 2 tin cans and a string because I can't afford the iPhone. So I thought that must be it. So I picked up a landline and I called the cardiologist again. I said, I think it's imperative that you come down here so we can discuss this because there is an immediacy. She is actively dying now. And regardless of what we can do to her, we're not going to beat Mother Nature. Storming in through the ICU, pulled aside. All you do is euthanize people. As an aside, he received an anonymous Christmas gift of a Merriam-Webster's dictionary, highlighting what the definition of euthanasia is. I said, with all due respect, this is not about me, this is not about you, this is about her. She has the right to choose how she wants to live her life. I asked her last night if she wants to die. It's the wrong question. How do you want to live, regardless of what you're dealing with? That's the question. You are actively dying. What is important to you? How can we deliver on that? Well, this will go against my 30-day mortality. With all due respect, I'm happy to contact legal because she has not only an ethical right, but a legal right not to be intubated. Whatever differences we have, we can settle later. But right now, the focus needs to be her. So in a huff and a puff, he said, okay. We got her home. She died the next day, comfortable in her own bed, surrounded by family. Why does this happen? Again, we talked about society. I think matriculation, we are taught as physicians to recognize disease and debility and to do something to it. And if we see an increase in disease or debility, we do more things to it, irrespective of where someone is at on their journey. We are so myopically focused on disease and avoiding the inevitability of life, which is death, that we lose sight of the human being. The system of education and the system of healthcare has failed us all. We are taught to combat cancer, lung disease, dementia. At the end of the day, while we may stave off its progression, put people into remission, overcome pneumonia, slow down the progression of dementia, the end result is the same. But the way we're trained and the way we are taught to practice medicine leads to a circular pattern of inevitable failure. I was unable to change the outcome of this journey. So there's society, there's how we're trained. The system precludes true value-based care. We're taught to do things to people, again, rather than for them and with them. How do we shift? How do we go from this transactional relationship to a translational one? How do we overcome the barriers and impediments that are integrated into our DNA, if you will? So if you'll just indulge me in an art analogy for a moment, please. How many here in the room have been to Amsterdam? I do not need to know why. Amsterdam is a halfway point on some work I've done in Tanzania. And in Amsterdam is the Rembrandt Museum. Who's familiar with Rembrandt? Renaissance painter, Dutch. The Italians describe Rembrandt's work as having chiaroscuro, light out of darkness. And whether it's a cold, wintry day in January or a warm day in June, every time I've been to the Rembrandt Museum and I've stood in front of a self-portrait of Rembrandt, there is tremendous value And it is emotional, the power, the brushstrokes, the color palette. But every time I am there, it is static. It doesn't change. And over the years, as I've practiced medicine and reflected on these experiences, that to me represents the greatest challenge that faces us today. The static nature of that portrait illustrates the linear algorithm of healthcare. If A, then B, then C, then D, at the exclusion of everything else that's around. The Rembrandtian algorithm that we're trained in precludes us from truly seeing and caring for a segment of the population that I would offer needs us the most. It's my mother, it's your mother, it's many of ours mothers and fathers, friends, colleagues. Who has been to the Museum of Modern Art in New York City? Same scenario, cold winter day, warm summer, morning, night, New York City, perhaps hungover just a bit. And I stand in front of a Jackson Pollock. Familiar with Jackson Pollock? Abstract expressionism, lines all over. Again, tremendous value, the color palette, the brush strokes, anything but static. And every time I see a Jackson Pollock, even if it's 2 or 3 or 4 times in the same visit, it is a different painting. It reflects on me who I am, what my journey has been, what is important to me. Now, there's always the family that says, little Tommy, just keep walking. You don't need to see that because it doesn't make sense. It's not static. It's not a Rembrandtian picture. It challenges us to accept what I offer is life's true algorithm, and that's ambiguity. Aside from the line in the sand that is an absolute for all of us, every moment we have until then is fraught with ambiguity. That is, from my perspective, life. You overlay a Rembrandtian practice on life, it is antithetical to truly caring for people, particularly at the end of life. And I don't just mean 3 days, 6 days, 7 days. It can be weeks, months, or years. What does a Rembrandtian mentality prevent us from doing? Telling the truth. If you put any diagnosis in front of us as providers with absolute certainty, we can say, I know where that's going. We have evidence, we have empirical experience. I may not know exactly when, but I know what that journey is going to be like. Rembrandtian algorithm prevents me from saying dementia is a progressive, irreversible, fatal disease. Rembrandtian algorithm prevents me from saying you are actively dying now from your widely metastatic recurrent cancer. What do you want? How do you want to live? Rembrandtian algorithms prevent us from saying you have a widely metastatic pancreatic cancer. How do you want to live? This is what that means. When we embrace ambiguity, we're able to come to the table and with absolute certainty say what these things are. Good, bad, or indifferent, it's your life. I need to be a steward of that life. My fiduciary responsibility is to care for you and to bring forward a truth that is outside this paradigm of Rembrandtian medicine and can offer options of care pursuant to what's important to you that are not necessarily a Whipple procedure and third-line chemotherapy or an LVAD or this or that. Why don't we do it? It's not just society and matriculation, it's fear. Our own frailty as human beings is fear of the unknown. Are they going to think we are failing them if we don't continue to offer treatment options? We are not obligated to offer treatment that will have no positive effect. And with absolute certainty, we know there's 5 to 10% of the population, everything that's done to them does not potentiate increased life expectancy or quality. When we embrace ambiguity, we can turn the closet light on, and there is no closet monster. There's nothing to be afraid of. We can tell the truth. It is empowering. It doesn't steal hope. We have to be explicit on what we hope for. To overcome Mother Nature? Absolutely can't happen. We have to define what we fight for. Fighting is not synonymous with treatment. Fighting is synonymous with honoring an individual. And to those who have heard or who have offered, there is nothing else we can do. It's the most egregious statement that there is, because first and foremost, we can always care. And care starts at diagnosis. What we say matters. The meter, the verse, the rhyme. We may think our patients hear what our intent is, but evidence suggests they don't. A disproportionate people with metastatic cancer think it's curable. Even when we say we can't cure that, I say the same thing to someone with a cold. I can't cure that. Do they hear anything different? No. A cold is a lot different than metastatic cancer. It's a lot different than end-stage heart failure. It's a lot different than end-stage dementia. We need to shift how we think and how we engage with patients. We need to tell the truth, the absolute truth, outside of this linear algorithm. We need to find the strength to put that right in front of somebody and find alternative mechanisms of caring for them outside of doing things to them. We're stealing from people if we don't. Danielle, who's a good family friend, came to me about 10 years ago. I've been diagnosed with breast cancer. Not sure what's going on. Can we talk? So 3 kids, friends with my kids. My wife and I went to their house. Her parents were there. Her husband's parents were there. She said, here's what I've been scheduled for the next 12 plus months. Bilateral mastectomy, hysterectomy, chemotherapy, radiation. What is cancer? I said, this is what cancer is. This is what breast cancer is. This is what your type of breast cancer is. 5 minutes into the conversation, she said, stop. Could I die from this? You could. I had no idea it was this serious. How do we get this far without true informed consent? Patient-centric care is not, do you want to start your chemotherapy on Tuesday or Thursday? Okay? Patient centricity is, this is a disease that could have this outcome. We're going to walk it every day, and the pathway is defined by you. We talked about treatments, we talked about symptom management, and then we talked about the emotive, the spiritual, and the social aspects of a disease that are going to change her perception of self, her as a mother, spouse, etc. 15 months later, she comes out. We've walked the journey together, and she's doing phenomenally well. Without true informed consent, regardless of the outcome, we have failed as a profession. With true informed consent, regardless of outcome, it is a success. As a palliative and hospice physician, I am about life. I am not about discontinuing things. I am not about talking people out of treatment. Andy Billings, a physician from Harvard, palliative care, died on a ventilator after 2 bone marrow transplant failures. That was a success true informed consent, he knew darn well what was going on. We need to shift how we think about palliative medicine and hospice. We need to move away from fear and the line of death and talk about living and life. What is at risk, ladies and gentlemen? We all know the economics. 5% of our population takes 50% of the healthcare dollar, $2.7 trillion in 2017. I'd offer at this rate, if we don't change, we're all out of a job. If you like what you do and you want to continue to care for people, we need to shift how we think and how we approach this population. Jonathan Glover, an author who wrote about the atrocities of the 20th century, the Holocaust, Rwandan genocide, the Gulag in the Soviet Union, he states, we need to overcome those barriers that drown out the flame that is empathy, which resides in all of us. Our matriculation, our society, our system has drowned that out because every day we are hurting people gravely at times. We are stealing from them the opportunity to choose how they want to live their lives based on the absolute truth. Are we not iatrogenically perpetuating the greatest series of atrocities the earth has ever known? I would argue yes. We have to hold ourselves accountable and responsible. We know that if we shift our perspective, we don't steal hope. In my 10-year patients surveyed, 98% patient satisfaction, and most likely to refer to others. Not stealing hope. Truth is empowering. From an economic perspective, 95% zero hospitalizations across all populations, all ages, over 5 years, and 70% per capita reduction in expenditures. People are living better pursuant to what is sacred to them, and it's the economic answer. And while it may sound dark, I offer we have hope. We have all of you. We have each other. We have the next generation of providers who are just graduating and coming into service. And so where do we go from here? We have to ask important questions of every patient every time. How are you? Fine. How are you? And we need to listen and hear. We need to ask, are you afraid? I'm not afraid of dying. It's interesting, it's not what I asked. I'm afraid of getting dead. I'm afraid of the unknown. Fear-based. It's not unknown. We know where this ends. We know what the path is. Let's enlighten people and support them on their journeys. What is sacred to you? It doesn't change if you have metastatic cancer or not. That's a tenet upon which everything we do should be delivered. And then lastly, the fourth question we should ask, what is your little voice telling you? While there's no scientific proof of what that little voice means, we know with absolute certainty it is always 100% correct. Unless we align ourselves with the clinical facts, what is sacred to someone and what their little voice says, we are negligent in fulfilling our responsibilities for caring for human beings. We have the opportunity to go out there and to change the world. We need to give ourselves permission to think differently. We need to implore each other to hold ourselves and our classmates, our attendings, our colleagues accountable for our actions, beliefs, and behaviors. We need to walk to that proverbial horizon at which we look out at the abyss and we redefine new truths about ourselves and our practice and how we can engage with a broader sense of the human condition beyond our own. We need to be a catalyst of that truth. We need to give ourselves permission and hold ourselves accountable to be a new voice in healthcare so patients can find their own. We need to give ourselves permission to care. This is the only way. It's the only way that we will connect beyond a Rembrandtian model which inhibits our ability to do what ultimately we want to do. This is the only way we can regain our humanity in healthcare and beyond. Thank you very much.